when we say community supports in relation to HIV and hepatitis C, I figure there were four main kind of groups or types of organizations we're talking about. The first type we called a CBAO and ASO. It's a community-based HIV/AIDS organization or HIV/AIDS service organization. So those are organizations that were developed really by a group of community members, and most of them formed more than 2 decades ago, some even 30, 31 years old, that provide services specifically to people who are living with and affected by HIV, and in the past few years have really been expanding their mandate to include hepatitis C and other sexually transmitted infections or bloodborne infections. The second kind of community support you might access is a community health center. You might be familiar with one near where you live. Most have their services restricted to particular postal codes. So that could be like Sherburne Health Center, Regent Park Community Health Center. Those are just a couple examples. And they provide medical treatment along with providing kind of social support, emotional support, practical assistance. The third community support is a community group. Now that could be something that's funded through the City of Toronto, like the 519 Church Street Community Centre. It could also be a group that's run by volunteers that meet on a regular basis. And then the last kind of community support is resources. So Dr. Wong mentioned how quickly information on hepatitis C can change. In fact, the pamphlet provided by Katie, Canada's source for HIV and hepatitis C information, was just updated this year. So moving on to the OHTN's rapid response. So this is a service that the OHTN provides to the first community support organization type I mentioned, the CBAOs or ASOs. So a community-based HIV organization can ask questions to the OHTN, and the OHTN will do a literature review, and they're very quick on the turnaround and very thorough. And so I thought in terms of talking about what community supports might look like, it would be good to take a look at this rapid response conducted last June on case management and community engagement models. The specific questions that were asked of the OHTN were what case management, community capacity building, and community development models exist for people living with or at risk of mental health issues, substance use, HIV, and hepatitis C. Number 2, are these models effective? And number 3, are there natural connectors and or barriers for integrating community capacity building or community development into case management models? Just to quickly summarize what the OHTN found in terms of models of case management. And when we say case management in literature, most of the literature reviewed from the OHTN in this rapid response was in the States. Case management in the context of an ASO or community-based HIV organization is really part of what kind of any service you might receive from that organization. So you might receive service from someone whose job title is case manager. Their job title might be community liaison, social worker, community worker. There's a broad scope. However, these models of case management, there's probably some similarities in what kind of service you're receiving from a community support. And we'll have some discussion afterwards about if these models resonate for you, if you recognize them in terms of service you might have received or you might have heard about, and if they differ. So the types of models that the OHTN found when they did their rapid response, number 1 is broker and generalist, which could really be one of 2 things. It could either be a very brief approach where a worker would identify someone's needs and link that person to appropriate service providers through referrals. So you'd say, I need housing, I need to find out about treatment, I don't know anyone else living with HIV and hepatitis C, I want to meet other people. And the person you're speaking to would then help you research and find out exactly where you can find all of these different services. And then you would do the work and make those phone calls and get connected to the services. Now, that could be a single appointment where you're accessing services from a number of different organizations, or it could be, say, at a community health center where maybe all of those services are provided by the same organization. And so maybe that would be a bit more of an intensive interaction with your worker or your case manager, where they would check in with you on a regular basis about how it's going accessing this part of the agency, that part of the agency. Another model is assertive community treatment. This is when a person is assigned a team that works under the direction of a mental health professional. So you come in and you say, you know, I'm living with HIV and hepatitis C, need all these things, and the worker says, well, we're going to assign an entire team to work with you. The rapid response did note that this model has been criticized as being paternalistic, coercive, and contradictory. However, I've certainly seen this model in action, so I know it's used. What's interesting is that the effects do not differ greatly from the brief contact broker and generalist model. So being assigned a whole team of people is not any more helpful than a single session when you're able to actually identify your needs, which I think says a lot. The models get better from here. There's the strength-based case management model, which really seems to be the more effective of these first four. And that's where the individual is able to identify what they would like to get from the interaction. What they're already doing well is really drawn out and emphasized. And steps to change or improvements made really come from the person themselves. Whenever I think about someone asking my advice on should I start HIV treatment or should I start hepatitis C treatment, I always think of the example of smoking cigarettes. And I think it's become commonly accepted knowledge that smoking cigarettes can be a harmful activity. It's on all the cigarette packs, and yet people still smoke cigarettes. And if you say to someone, don't smoke cigarettes, they're bad, will that actually lead to any meaningful change in the person? Or will they just say, I know that, I'm still going to do it? And so what the nice thing about the strength-based case management model is if you go to a worker and you say, I don't want to start HIV meds, they might ask you, well, what are the benefits of that decision? And so it's turning a different lens or framework onto the decision or the choice that you're looking to make and trying to figure out exactly what you want. The last two models, community readiness and community health action, are more about kind of overall organizational or programmatic approaches. So community readiness is when a service provider or an organization would figure out if there's a specific community that might benefit from a program. And then the community health action model is when the people that are affected, so the community, actually get involved in figuring out what that response would look like or what that program would look like. And that's often through what we call PAR, participatory action research. So it's kind of a very theoretical review of the literature, but I thought it might ground our conversation a little bit. So it's certainly my opinion, and it was mentioned in the rapid response, that when you take that assertive framework and you try to, as a worker, coerce people into making a decision, that's a very ineffective way of providing service. If the person makes their own decision with the correct information and as much knowledge as they can get, that's a much more effective response. So I would caution against providing a lot of coercive language or information about a particular decision, because ultimately it's the person's autonomous choice to make.